If you are over 60 and you are taking more than one prescription medication right now, which describes the overwhelming majority of adults in this age group, there is a meaningful possibility that one of those medications is quietly working against the arthritis treatment you are also receiving. And nobody has ever told you this. This is different from the broader medication-arthritis connection we covered in a previous video on this channel. Today we are focusing specifically on adults over 60, because age changes everything about how medications interact with your joints. Your kidney function has declined. Your liver metabolizes drugs differently than it did at 40. You are far more likely to be taking multiple medications simultaneously, a situation called polypharmacy that creates interaction risks that simply do not exist for someone on a single prescription. And the medications most commonly prescribed specifically for conditions that become more common after 60: high blood pressure, high cholesterol, sleep difficulties, and chronic pain itself include some of the most well-documented arthritis aggravators in the entire pharmaceutical landscape. Today I am going to walk you through 5 specific pills that are disproportionately likely to be in the medication cabinet of someone over 60, and that have research documented effects on arthritis specifically in this age group, effects that are often more pronounced than in younger patients because of the age-related physiological changes we just mentioned. I am going to explain exactly why each one matters more after 60 than it did when you were younger, and exactly what conversation you need to have with your physician about each one. Before we begin, subscribe to this channel right now if you want evidence-based health guidance specifically designed for adults over 60 managing arthritis and the complex medication landscape that comes with this stage of life. We create this content every week because the information that matters most often depends entirely on your specific age and health context, and generic advice simply does not serve this community well. Hit subscribe. Let us start with why age itself changes the relationship between medications and arthritis, because this context is essential to understanding why the 5 pills we are about to discuss deserve more scrutiny in someone over 60 than the identical medication would in someone 40 years younger. Kidney function declines progressively with age, even in the absence of any diagnosed kidney disease, through a process called age-related nephron loss that begins around age 40 and accelerates after 60. This matters enormously for arthritis medications and for the medications we are about to discuss, because the kidneys are the primary route by which the body clears uric acid. And many of the medications that affect arthritis do so specifically through their effects on kidney handling of this compound. A medication that has a modest uric acid elevating effect in someone with normal kidney function at age 40 can have a substantially larger effect in someone over 60, whose baseline kidney clearance capacity is already reduced, simply because there is less reserve capacity available to compensate for the medication's effect. Liver metabolism of medications also changes with age, generally slowing down, which means that medications can remain active in the bloodstream longer than they would in a younger adult, extending the duration of any joint-relevant side effect. And the simple mathematics of polypharmacy, the technical term for taking 5 or more medications simultaneously, which describes a substantial proportion of adults over 65 according to research on prescription patterns in this age group, means that the interactions between medications, not just the individual effects of any single medication, become increasingly relevant to understand. The first pill that may be making your arthritis worse after 60 is the proton pump inhibitor, the heartburn and acid reflux medication including omeprazole and pantoprazole that we touched on in our previous medications video. But that deserves specific, dedicated attention for the over 60 population because of how disproportionately this medication is prescribed for long-term, often indefinite use in exactly this age group. Acid reflux becomes more common with age, due to changes in esophageal sphincter function and stomach acid dynamics, which means that adults over 60 are substantially more likely than younger adults to be on long-term proton pump inhibitor therapy, frequently started years or even decades earlier, and simply continued without periodic reassessment of whether the medication is still necessary. Research has associated long-term proton pump inhibitor use with increased rheumatoid arthritis risk and disease activity, with reduced magnesium absorption that affects pain modulation, and additionally, specifically relevant to the over 60 population, with reduced calcium absorption that can worsen the bone density concerns that frequently coexist with osteoarthritis in this age group, since proton pump inhibitors reduce the stomach acidity needed for optimal calcium absorption from food and supplements. The specific concern for adults over 60 is the duration of use. Many adults in this age group have been taking a proton pump inhibitor continuously for 5 10 or even 20 years, having started it for an acute reflux episode decades earlier and simply never stopped, often without their physician ever revisiting whether the original indication still applies or whether a lower dose or an alternative medication might now be more appropriate. Gastroenterology guidelines specifically recommend periodic reassessment of proton pump inhibitor necessity, particularly in older adults. Given the accumulating evidence of long-term risks, including the arthritis-relevant effects we have described alongside the bone density and other concerns associated with prolonged use. The second pill is the daily low-dose aspirin, prescribed for cardiovascular protection, which becomes dramatically more common after 60 as cardiovascular risk increases with age, meaning that a substantial proportion of the over 60 population is taking this medication specifically because of their age-related cardiovascular risk profile. We discussed the uric acid elevating paradox of low-dose aspirin in our previous medications video, but the specific relevance to adults over 60 deserves emphasis. Gout itself becomes more common with age, with the combination of declining kidney function, increased likelihood of diuretic use for blood pressure management, and now this aspirin effect creating a kind of perfect storm of uric acid elevating factors that converge disproportionately in exactly this age group. Research on gout prevalence has documented that the condition's incidence rises substantially after age 60, and the medication landscape typical of this age group aspirin, diuretics, and sometimes statins or niacin, as we discussed previously, contributes meaningfully to this age-related increase beyond what aging alone would explain. This does not mean adults over 60, who need aspirin for genuine cardiovascular protection, should discontinue it. The cardiovascular benefit in appropriate patients is well established, and the stakes of cardiovascular events in this age group are serious. But it does mean that if you are over 60 on daily aspirin and experiencing new or worsening joint pain, particularly sudden, severe pain in a single joint, especially the big toe, ankle, or knee, consistent with a gout flare pattern, this medication should specifically be part of the conversation with your physician about what might be contributing. Before we continue with the remaining 3 pills, here is your pause. Are you over 60 and currently taking either a proton pump inhibitor or daily low-dose aspirin? And have you had a conversation with your physician within the past year about whether these medications are still necessary at their current dose? Drop a comment below right now and tell us. This information is genuinely useful for understanding how common these long-term, unrecessed prescriptions actually are in this community. We read every comment. The third pill is the sleep medication category, specifically the benzodiazepines and the so-called Z drugs like zolpidem, commonly prescribed for the sleep difficulties that become substantially more common after 60, and that deserve specific attention for an arthritis-relevant mechanism that is rarely discussed in the context of joint health. These sleep medications do not have a direct pharmacological effect on uric acid or inflammatory cytokines in the way that the other medications in this video do. Their relevance to arthritis after 60 operates through a different and equally important mechanism. Sedative sleep medications increase the risk of falls in older adults, a risk that is already elevated in this age group due to the balance and proprioceptive changes of aging that we have discussed in previous videos, and that becomes substantially more dangerous specifically for adults who already have compromised joint structure from arthritis. A fall onto an already arthritic hip, knee, or wrist carries a meaningfully higher risk of fracture or significant joint trauma than the same fall in a joint with healthy, undamaged cartilage and bone, and research has specifically documented that benzodiazepine and Z drug use in older adults is associated with significantly increased fall risk, with some studies suggesting the magnitude of this risk increase is comparable to or exceeds many other commonly cited fall risk factors in geriatric medicine. Additionally, sedative sleep medications can mask or blunt the early morning stiffness and pain signals that we have discussed throughout this arthritis series as important diagnostic and monitoring information, potentially delaying recognition of arthritis progression or flares because the medication's sedating effects interfere with the normal sensory feedback that would otherwise prompt earlier attention to a worsening joint condition. For adults over 60 managing both arthritis and sleep difficulties, this represents a situation where the comprehensive, evidence-based sleep optimization strategies we detailed in our Before Bed Fruits video, which work through entirely different, non-sedating mechanisms involving melatonin and anti-inflammatory polyphenols rather than central nervous system, depression may offer a path to improved sleep that does not carry the same fall risk and symptom masking concerns as pharmaceutical sedative hypnotics. A conversation worth having with your physician if you are currently relying on these medications long-term. The fourth pill is oral corticosteroids, specifically prednisone, prescribed for a wide range of conditions including chronic obstructive pulmonary disease exacerbations, severe allergic reactions, and various inflammatory conditions that become more common with age, and that create a uniquely complex relationship with arthritis that deserves careful explanation because corticosteroids are simultaneously one of the most effective anti-inflammatory medications available and one of the most significant long-term risks to joint health when used beyond short-term acute treatment courses. In the short term, corticosteroids powerfully suppress the inflammatory cytokine production we have discussed extensively throughout this series, often providing rapid and substantial relief from arthritis flares, which is precisely why they are sometimes prescribed specifically for this purpose. But with prolonged use, generally considered to be more than a few weeks of continuous treatment, though even shorter courses carry some risk. Corticosteroids produce well-documented and significant negative effects on bone density through their suppression of osteoblast activity and promotion of osteoclast activity, accelerating the bone loss that frequently coexists with and complicates osteoarthritis in adults over 60. Corticosteroids also impair the collagen synthesis that cartilage and connective tissue repair depends on, potentially undermining the very tissue repair processes that the comprehensive arthritis management approach we have detailed throughout this channel, the exercise, the nutrition, the targeted supplementation is working to support. The specific concern for adults over 60 is that this population is more likely to be prescribed corticosteroids for a wide range of age-related conditions, more likely to experience the bone density effects given the baseline age-related bone loss already occurring, and more likely to be on prolonged or repeated courses for chronic conditions rather than the brief, acute courses for which corticosteroid risk is most favorable. If you are over 60 and on an oral corticosteroid for any condition, ensuring that your physician is actively monitoring your bone density, considering the lowest effective dose for the shortest necessary duration, and discussing the vitamin D and calcium status that we have detailed extensively throughout this arthritis series as relevant to bone and joint health, represents an essential component of using this powerful but genuinely double-edged medication category responsibly. The fifth and final pill is the opioid pain medication category, specifically the long-term use of opioids including oxycodone, hydrocodone, and tramadol for chronic pain management, a practice that became substantially more common in past decades for managing arthritis pain specifically, and that more recent research and clinical guidelines have significantly reconsidered, particularly for the over 60 population. Long-term opioid use in older adults carries the well-documented risks of falls and cognitive impairment that we have discussed in the context of sedative sleep medications, risks that compound directly with the joint vulnerability of existing arthritis in exactly the way we described for benzodiazepines. But opioids also have a specific and less widely known relationship to pain processing itself. Research has documented a phenomenon called opioid-induced hyperalgesia, in which prolonged opioid use can actually increase pain sensitivity over time through changes in central nervous system pain processing, potentially worsening the central sensitization component of chronic arthritis pain that we have discussed extensively throughout this series rather than simply providing the pain relief these medications were prescribed to achieve. This means that for some adults on long-term opioid therapy for arthritis pain, the medication itself may be contributing to a cycle of worsening pain perception that creates the appearance of arthritis progression or flare, when the underlying mechanism may actually be related to the pain medication's own effect on the nervous system. Current clinical guidelines for chronic non-cancer pain, including arthritis pain, increasingly recommend opioids as a later-line option after the comprehensive non-pharmacological and non-opioid pharmacological approaches we have detailed extensively throughout this channel have been appropriately trialed, reflecting both the fall and cognitive risks we have described and the genuine concern about opioid-induced hyperalgesia undermining rather than supporting long-term pain management. For adults over 60 currently on long-term opioid therapy for arthritis pain, this is not a video suggesting abrupt discontinuation, which can itself be dangerous and must be managed carefully by a physician, but rather an invitation to have a specific conversation about whether the comprehensive program we have built throughout this entire channel, the exercise, the anti-inflammatory diet, the proven supplements, the topical treatments, the appropriate use of non-opioid medications has been fully implemented as part of a structured plan to potentially reduce reliance on opioid medication over time, under appropriate medical supervision. Now let us talk about what brings these 5 pills together, and what you should actually do with this specific over 60 focused information. Each of these 5 medications, proton pump inhibitors, low-dose aspirin, sedative sleep medications, oral corticosteroids, and opioid pain medications represents a situation where the medication's relevance to your arthritis is amplified specifically because of physiological changes that accompany aging, reduced kidney clearance, increased fall risk, increased baseline bone loss, and the simple statistical reality that adults over 60 are more likely to be taking several of these medications simultaneously, creating compounding effects that a single medication conversation does not fully capture. The specific action this information should prompt is what we might call a comprehensive medication reassessment, ideally conducted annually for adults over 60 regardless of whether any new symptoms have prompted concern, because the gradual, cumulative nature of many of these medication arthritis interactions means that meaningful effects can develop slowly over years without an obvious triggering event that would otherwise prompt you to question a long-standing prescription. This reassessment is most effectively conducted as a comprehensive review of your complete medication list with either your primary care physician or a pharmacist specifically trained in geriatric medication management, examining each medication for continued necessity, appropriate dosing for your current kidney and liver function, and potential interactions both with each other and with the arthritis you are managing. The specific question of drug-drug interactions among these 5 medications, and between these 5 and the broader cardiovascular and metabolic medications common in adults over 60, deserves additional detail because the over 60 population is precisely where these interaction risks concentrate most heavily. Consider the realistic scenario of an adult over 60 managing high blood pressure with a diuretic, taking daily low-dose aspirin for cardiovascular protection, using an over-the-counter proton pump inhibitor for occasional heartburn that has quietly become daily long-term use, and occasionally taking a sleep aid for difficulty falling asleep, perhaps related to discomfort from the very arthritis this video is addressing. This is not an unusual or extreme medication profile for this age group. It is, if anything, a fairly typical one. Within this profile alone, we have 2 medications independently elevating uric acid through different mechanisms. One medication potentially affecting magnesium and calcium absorption relevant to both pain modulation and bone health, and one medication carrying fall risk that becomes more consequential given whatever joint vulnerability already exists from the arthritis being managed. This is precisely why a comprehensive medication review, rather than addressing each prescription in isolation as different specialists write them for different conditions, becomes increasingly essential as the number of concurrent medications increases, which it reliably does with advancing age. Research on polypharmacy in older adults has consistently found that the risk of adverse drug interactions increases non-linearly with the number of concurrent medications, meaning that the jump from 4 to 5 medications carries proportionally more interaction risk than the jump from 1 to 2. A mathematical reality that makes the comprehensive review approach increasingly valuable precisely in the population, adults over 60 with multiple chronic conditions, where it is most likely to be needed and least likely to be happening systematically. The role of the annual wellness visit, specifically the Medicare annual wellness visit available to adults over 65 in the United States, deserves mention as an underutilized opportunity for exactly this kind of comprehensive medication review. This visit is specifically structured to include a review of current medications and bringing a complete, written list of every medication, supplement, and over-the-counter product you take, along with the specific questions this video has raised about the 5 medication categories we have discussed, can transform this often briefly conducted visit into the kind of substantive medication reassessment that adults over 60 managing arthritis alongside other chronic conditions genuinely benefit from. The concept of deprescribing, the deliberate, physician-guided process of discontinuing or reducing medications that may no longer be necessary or whose risks now outweigh their benefits given an individual's current health status and goals, has emerged as a specific area of geriatric medicine research precisely because of the polypharmacy patterns we have described throughout this video. Deprescribing is not the same as simply stopping medications. It is a structured, evidence-based process that considers the original indication for each medication, whether that indication still applies, the current evidence for continued benefit at this stage of life, and the specific risks, including the arthritis-relevant risks we have detailed in this video, the continued use may carry. For adults over 60 who recognize their own medication profile in several of the 5 categories we have discussed, asking your physician directly whether a deprescribing conversation is appropriate for your specific situation is a productive, specific way to bring this video's content into your actual care. The cumulative message of both this video and our previous video on medications and arthritis flares is one that deserves explicit articulation. Arthritis management for adults over 60 cannot be fully separated from the broader medication landscape of managing multiple chronic conditions simultaneously, a reality that becomes the norm rather than the exception at this stage of life. The comprehensive arthritis management program detailed throughout this entire channel, the exercise, the diet, the supplementation, the appropriate topical and pharmacological treatments, achieves its fullest potential when it operates within a medication environment that has been actively reviewed and optimized, rather than one where unrecognized medication effects are quietly working against the very joint health you are working so hard to protect through every other component of your comprehensive approach. You are over 60. You deserve a medication regimen that has been specifically evaluated for your current life stage, your current kidney and liver function, and your current arthritis management goals, not simply the accumulated prescriptions of decades of treating individual symptoms as they arose, never revisited as a complete picture. This video has given you the specific knowledge to request that complete picture review. Use it. This video has given you the specific, age-relevant knowledge that the general population medication arthritis connection we covered previously does not fully capture. The 5 medications most disproportionately relevant to adults over 60 specifically, the physiological reasons why age amplifies these particular interactions, and the structured approach to bringing this information into a productive conversation with your healthcare team. This is not information designed to make you fearful of medications that may be genuinely necessary for serious conditions. It is information designed to ensure that you and your physician are making fully informed decisions about your complete medication regimen, with the arthritis-specific considerations relevant to your age explicitly part of that conversation rather than an unrecognized factor working against the arthritis management you are otherwise pursuing. If this video gave you the specific, age-relevant medication knowledge that you needed and that nobody had explained to you before, please support this channel. Hit the like button right now. Subscribe if you have not already, because we are building the most comprehensive resource specifically for adults over 60 managing arthritis and the complex medication landscape this stage of life involves. Share this video with someone over 60 who is managing multiple medications and arthritis simultaneously and who needs this specific information. And leave a comment below. Tell us which of these 5 pills you or someone you care for is currently taking, and what you are going to ask your physician at your next appointment. We read every comment. Thank you so much for watching. See you in the next one.